In the previous lectures we discussed hypertension pathophysiology and treatment. Today we'll start talking about diuretics. But first there are some basics we should know about renal physiology and sodium reabsorption process. Simply, what are the diuretics? They are drugs that increase urine output, by decreasing renal sodium reabsorption by different mechanisms, and this increases loss of sodium in water in urine. Let's briefly talk about some renal physiology basics. The kidneys play an important role in maintaining the volume and composition of extracellular fluids, by selective regulation of solute and fluid reabsorption. Each kidney is composed of two parts, cortex and medulla. Renal blood flow, the volume of the blood delivered to kidney per minute, equals 1,200 milliliters per minute. Glomerular filtration rate, the volume of fluid filtered by renal glomerulus per minute, equals from 90 to 120 milliliters per minute, that equals 170 liters per day. About 99% of the filtrate is reabsorbed by renal tubules into the blood, so about 1.5 liters per day, from the filtered 170 liters per day, is excreted as urine. The functional unit of excretion in kidneys is nephron. Each kidney contains about 1 million nephrons. Nephron consists of glomerulus, proximal convoluted tubule, loop of Renal, distal convoluted tubule, and collecting tubule. Now let's talk about the steps of excretion. The first step is glomerular filtration. First, blood goes to the glomerulus through the afferent arteriole to be filtered by diffusion, under high pressure in Bowman's capsule, then blood is discharged to the efferent arteriole. Small molecules and ions can easily pass to the filtrate, but big molecules such as RBCs and plasma proteins, with any drugs bound to them, cannot pass. That means they are not filtered. The second step is tubular reabsorption. The body discovers that it needs most of the materials that present now in the filtrate. So reabsorption of sodium, water and any needed material from the tubules lumen to the blood occurs. And this is done in nephron parts other than glomerulus. Each part of them has certain capacity of reabsorption process. Proximal convoluted tubule is responsible for reabsorption of about 65% of sodium ions. Loop of Renal, 25% of sodium ions. Distal convoluted tubule, 6% of sodium ions. Collecting tubule, 4% of sodium ions. Note that wherever sodium goes, water goes, so as sodium reabsorption increases, water reabsorption increases. The third step is tubular secretion. The body chooses to discharge some materials actively, using carriers and energy from the blood directly into the tubular lumen, to the filtrate. Now let's discuss sodium reabsorption mechanisms, to be able to understand the mechanisms of the different groups of the diuretics. Proximal convoluted tubule. Responsible for reabsorption of 70 to 75% of filtrate from urine to blood. 65% of sodium is reabsorbed, as the concentration gradient between filtrate and blood is very high. High concentration of sodium in filtrate, so sodium moves from filtrate to blood by passive diffusion by two transport systems. The first one is symporter or cotransport, which is a carrier for reabsorption of two or more molecules in the same direction. And it is responsible for the reabsorption of sodium with glucose, or amino acids. And the second is antiporter, which is a carrier for exchange of two molecules in opposite directions. And it is responsible for the reabsorption of sodium and excretion of a proton. Firstly, sodium enters the cell of the lumen through an antiport mechanism in exchange with a proton. Then it is discharged into the blood through sodium-potassium ATPase pump. Then a proton present in urine binds to bicarbonate, to form carbonic acid, which then dissociate to carbon dioxide plus water, released in urine. Carbon dioxide diffuses, and react with water again to enter another cycle, and so on. The binding and dissociation of carbon dioxide and water into carbonic acid, is mediated by carbonic anhydrase enzyme, This enzyme is responsible for production of protons that help sodium to enter the cell, so if this enzyme is inhibited, sodium will not be reabsorbed from this part of nephron. Loop of Henle. It normally causes 25% of sodium reabsorption, but also it can compensate the reabsorption of sodium if it was inhibited in proximal convoluted tubule. It consists of descending limb, base and ascending limb. In descending limb, water can pass from the lumen to the blood till reaching the base, where water reabsorption stops. The ascending limb contains the sodium potassium chloride symporter carrier, which is responsible for 25% of sodium reabsorption. Then sodium is discharged into the blood through sodium potassium ATPase pump. Calcium and magnesium pass freely to blood in the same direction of sodium ions. Distal convoluted tubules are responsible for reabsorption of 6% of sodium using sodium chloride symporter carrier. Then sodium is discharged into the blood through sodium potassium ATPase pump. Here reabsorption of sodium is associated with secretion of calcium ions from the blood to urine. Collecting tubules are responsible for reabsorption of 4% of sodium. Collecting ducts are under hormonal control. Vasopressin, or antidiuretic hormone, ADH, which is responsible for water reabsorption. And aldosterone, which is responsible for sodium reabsorption and potassium secretion. In the next lecture we'll discuss the carbonic anhydrase inhibitors, osmotic diuretics, loop diuretics, thiazide diuretics and potassium-sparing diuretics. We'll talk about their actions, uses and side effects. From the previous lecture we know that there are some important carriers, enzymes and hormones involved in sodium reabsorption. Simply, they are the targets for different kinds of diuretics, such as carbonic anhydrase enzyme, sodium potassium N2-chloride symporter, sodium N-chloride symporter, and hormones such as aldosterone and vasopressin. The first category we'll discuss is the carbonic anhydrase inhibitors, such as acetazolamide. As we know, carbonic anhydrase catalyzes the reaction of carbon dioxide and water, leading to the formation of carbonic acid, which spontaneously ionizes to a proton and bicarbonate. So the ability to exchange sodium for a proton is decreased in the presence of acetazolamide, results in a mild diuresis. Bicarbonate is also retained in the lumen, with marked elevation in urinary pH, that means that the urine becomes alkaline. The loss of bicarbonate causes metabolic acidosis, and decreased diuretic efficacy following several days of therapy. And phosphate excretion is increased by an unknown mechanism. So we can conclude the side effects of this drug: mild metabolic acidosis, potassium depletion, or known as hypokalemia, renal stone formation, as they increase excretion of calcium and phosphate in urine, forming calcium phosphate stones, that are insoluble in alkaline urine. The drug should be avoided in patients with hepatic cirrhosis, because it could lead to a decreased excretion of ammonia, so ammonia may reach the brain causing encephalopathy. Carbonic anhydrase inhibitors have a mild diuretic effect, as sodium that is not reabsorbed from PCT, can be reabsorbed from both loop of Henle and DCT. So they are used for their other pharmacologic actions. Acetazolamide decreases the production of aqueous humor, and reduces intraocular pressure in patients with chronic open-angle glaucoma, probably by blocking carbonic anhydrase in the ciliary body of the eye. Topical carbonic anhydrase inhibitors, such as torsemide and brenzolamide, have the advantage of not causing systemic effects. Acetazolamide can be used in prophylaxis of acute mountain sickness. It prevents weakness, breathlessness, dizziness, nausea, and cerebral as well as pulmonary edema characteristic of the syndrome. The second category we'll talk about, loop diuretics, or known as high-ceiling diuretics, such as bumetanide, furosemide, torsemide, and ethacrynic acid. Loop diuretics inhibit the cotransport of sodium, potassium N2-chloride, in the luminal membrane in the ascending limb of the loop of Renal. Therefore, reabsorption of these ions is decreased. These agents have the greatest diuretic effect of all the diuretic drugs. As we know, the ascending limb accounts for reabsorption of 25 to 30% of filtered sodium, and the following sites in the nephron are unable to compensate for the increased sodium load. The loop diuretics may increase renal blood flow, possibly by enhancing prostaglandin synthesis. Nonsteroidal anti-inflammatory drugs inhibit renal prostaglandin synthesis, and can reduce the diuretic action of loop diuretics. As we said before, due to normal reabsorption, there will be a certain normal voltage that causes calcium and magnesium ions to move from the tubular lumen to the blood through interstitial spaces. So, by using loop diuretics, sodium and potassium reabsorption are inhibited, leading to inhibition of calcium and magnesium reabsorption. In patients with normal serum calcium concentrations, hypocalcemia does not result, because calcium is reabsorbed in the distal convoluted tubule. The loop diuretics are the drugs of choice and are useful in emergency, for reducing acute pulmonary edema and acute or chronic peripheral edema, caused from heart failure or renal impairment. Because of their rapid onset of action, particularly when given intravenously. Loop diuretics, along with hydration, are also useful in treating hypercalcemia, because they stimulate tubular calcium excretion. They are also useful in the treatment of hyperkalemia. Now let's talk about their adverse effects. Loop diuretics can cause acute hypovolemia, because of the severe and rapid reduction in blood volume, with the possibility of hypotension, shock, and cardiac arrhythmias. Hypokalemia, and hypokalemic alkalosis. Hypomagnesemia may occur with chronic use of loop diuretics combined with low dietary intake of magnesium. Hyperuricemia occurs with the use of furosemide and ethacrynic acid, as they compete with uric acid for the renal secretory systems, thus blocking its secretion and causing gouty attacks. Ototoxicity, reversible or permanent hearing loss may occur with loop diuretics, and the risk increases with co-administration of other ototoxic drugs such as aminoglycosides antibiotics. Ethacrynic acid is the most likely to cause deafness. And the last category we'll talk about in this lecture is osmotic diuretics. These agents are hydrophilic chemical substances that are filtered through the glomerulus, such as mannitol and urea. They result in a higher osmolarity of the tubular fluid, and prevents further water reabsorption, resulting in osmotic diuresis. Osmotic diuretics are used to increase water excretion rather than sodium excretion, so they are not useful for treating conditions in which sodium retention occurs. They are used for patients with increased intracranial pressure or acute renal failure due to shock, drug toxicities, and trauma. Maintaining urine flow preserves long-term kidney function. Mannitol is not absorbed when given orally and should be given intravenously. Their adverse effects may include hypotension, reflex tachycardia, and extracellular volume expansion, temporarily, because the presence of mannitol in the extracellular fluid extracts water from the cells. The thiazides are the most widely used diuretics. They are sulfonamide derivatives, such as Chlorothiazide, which was the first orally active diuretic that could affect the severe edema, often seen in hepatic cirrhosis and heart failure, with minimal side effects. Hydrochlorothiazide is more potent, so the required dose for treatment is lower than that of Chlorothiazide. Chlorthalidone, Indapamide, and Metolazone are not truly thiazides, but are referred to as thiazide-like diuretics, because they contain the sulfonamide residue in their chemical structures, and their mechanism of action is similar to thiazides. All of thiazide diuretics have equal maximum diuretic effects, but differ only in potency. They cause diuresis by decreasing sodium reabsorption, mostly from the distal convoluted tubule. and this is done by inhibiting sodium and chloride cotransporter on the luminal membrane of the tubules, increasing sodium and chloride excretion, which leads to the excretion of very high prosmolar urine. As we said before, in DCT, sodium reabsorption is accompanied by calcium excretion in urine. So, when thiazides inhibit sodium reabsorption, they decrease calcium excretion in urine, causing hypercalcemia, in contrast with the loop diuretics, which increase the calcium concentration in the urine, causing kidney stone formation. So thiazides are suitable for patients susceptible to kidney stones. Thiazides also increase the loss of potassium and magnesium. With prolonged use, thiazides reduce peripheral vascular resistance. This is done by relaxation of arteriolar smooth muscle, causing vasodilatation by unknown mechanism. So we can conclude some of their adverse effects. The most frequent problem with the thiazide diuretics is hypokalemia, so potassium levels should be monitored, especially in patients receiving digoxin, as they may cause ventricular arrhythmias. Potassium deficiency can be overcome by using potassium-sparing diuretics, that we'll discuss in the next lecture. Thiazides cause hyponatremia. And they also cause hypovolemia, that can cause orthostatic hypotension. And as we said, they can lead to hypercalcemia. Thiazides increase serum uric acid, or known as hyperuricemia, and this is done by decreasing the amount of uric acid excreted by the organic acid secretory system, causing gouty attacks. So they should be used with caution in patients with gout or high levels of uric acid. Thiazides can cause hyperglycemia and glucose intolerance, so diabetic patients taking thiazides should monitor glucose, and adjust their diabetes therapy if needed. Let's talk about their therapeutic uses. The thiazides are a mainstay of antihypertensive medication. They are effective in reducing blood pressure in the majority of patients with mild to moderate essential hypertension. They can be used as a single medication, but sometimes additional antihypertensive medication should be given to control blood pressure. You can watch the previous lectures when we discuss the other antihypertensive medications. Note that, the antihypertensive actions of angiotensin-converting enzyme inhibitors are enhanced when given in combination with the thiazides. Although the diuretics of choice in reducing extracellular volume in heart failure are the loop diuretics, thiazide diuretics may be added, if additional diuresis is needed. The thiazides can be useful in treating idiopathic hypercalciuria, as they inhibit urinary calcium excretion. So they are beneficial for patients with calcium oxalate stones in the urinary tract. Let's briefly talk about the thiazide-like diuretics. Chlorthalidone, pharmacologically behaves like hydrochlorothiazide. It has a long duration of action, so it is often used once daily to treat hypertension. Metolazone is more potent than the thiazides. It can cause sodium excretion even in advanced renal failure. Indapamide has a long duration of action. At low doses, it shows significant antihypertensive action with minimal diuretic effects. It is metabolized and excreted by the gastrointestinal tract and the kidneys. It is useful for patients with renal failure. Potassium-sparing diuretics act in the collecting tubule, to inhibit sodium reabsorption and potassium excretion. So they increase the loss of sodium in urine causing diuresis, and increase the concentration of potassium in the blood causing hyperkalemia. There are two categories of drugs within this group: aldosterone antagonists, and sodium channel blockers. Let's first talk about aldosterone antagonists, such as Spironolactone and eplerenone. First, you should know that, in most edematous states, blood levels of aldosterone are high, causing retention of sodium. Spironolactone and eplerenone antagonize the activity of aldosterone, resulting in retention of potassium and excretion of sodium. They are competitive antagonists of aldosterone receptors, causing inhibition of sodium and potassium exchange sites of the collecting tubule, so increase the loss of sodium in urine, causing diuresis. Let's talk about their therapeutic uses. They have lower diuretic effect compared to other diuretics, but they are useful as they cause potassium retention in the blood. So they are often given in conjunction with thiazide or loop diuretics, to prevent potassium excretion that occurs with these drugs. Spironolactone is effective in clinical situations associated with secondary hyperaldosteronism, such as hepatic cirrhosis and nephrotic syndrome. In contrast, it has no diuretic effect in patients with no significant circulating levels of aldosterone, such as in Addison disease. Aldosterone antagonists are used in heart failure and hypertension. Spironolactone is effective in ascites, which is the accumulation of fluid in the abdominal cavity, that is a common complication of hepatic cirrhosis. Spironolactone is often used off-label for the treatment of polycystic ovary syndrome, as it blocks androgen receptors and inhibits steroid synthesis at high doses, so it can help to offset increased androgen levels seen in this disorder. Now let's talk about their adverse effects. Hyperkalemia. Spironolactone can cause gastric upset. It may also induce gynecomastia in male patients, and menstrual irregularities in female patients, as it chemically resembles some of the sex steroids. Eplerenone has less endocrine effects than spironolactone. And finally, let's talk about the other category, sodium channel blockers. Triamterene and amiloride block sodium transport channels, resulting in a decrease in sodium and potassium exchange. Their ability to block the sodium and potassium exchange in the collecting tubule does not depend on the presence of aldosterone. These agents also are not very effective diuretics, so they are commonly used in combination with other diuretics, for their potassium-sparing properties. The side effects of triamterene include potassium retention, increased uric acid and renal stones.